Good afternoon, my name is Maria Jimenez and I'm a doctor from Medellin, Colombia. Today, I'm going to be talking about what to do if your patient is incidentally found to have brain or spinal cord MRI lesions that are characteristic of demyelination, but he is completely asymptomatic. I chose this topic because we had several patients coming to the clinic being referred by their primary care provider or the emergency department doctor because they had a brain MRI done for different reasons, and the radiology report said that they had demyelinating lesions and that a diagnosis of multiple sclerosis must needed to be ruled out. So patients came in very anxious and worried about possibly having this condition. So I think it is very important for all doctors to know how to properly evaluate this type of patients. To start with, demyelinating lesions are areas of the central nervous system where the myelin sheath has been damaged, either by inflammation, infections, or vascular causes, among other things. Radiologically speaking, demyelinating lesions are defined as ovoid, well-defined, hyperintensities over 3 millimeters on T2 or flare sequences. So in the picture on the screen, we can see that on the right, we have a T2 sequence with multiple hyperintensities. In T2 sequences, both chronic and active lesions are seen as hyperintense, while on a T1 with contrast sequence, we can see the difference between active and chronic lesions. The active lesions are seen hyperintense or contrast enhancing, as we can see with the black arrows, and with the white arrows, we see a hypointense lesion, which means that it's a chronic lesion. On this other patient, we see two different sequences. On the T1 sequence on the left, we see a hypointensity that's localized periventricularly with the black arrow, and other hypointensities that are located juxtacortically with the white arrows. While on the figure on the right, we can see the same lesions, but they are hyperintense because it's a T2 flare sequence. There are multiple causes that can produce white matter changes. One of the main groups are the vascular causes, mainly migraine, specifically migraine with aura, and small vessel ischemic disease that can be associated with hypertension, diabetes, or just aging. In the inflammatory and infectious conditions group, we have multiple sclerosis, we have lupus, neurosyphilis, and Lyme disease. Sports such as boxing, rugby, or any type of contact sports, or even just the history of a traumatic brain injury in a motor vehicle accident or any type of accident can produce T2 white matter changes. Anti-seizure medications are related to transient white matter T2 changes, and the vitamin B12 deficiency mainly is associated with subacute combined degeneration, which produces changes on the white matter of the spinal cord, but it has been described that this condition can also produce brain white matter changes. I wanted to talk about this sign, which is a central vein sign, because even though it's mostly associated with neuroradiology, I found it interesting that among the different causes of T2 white matter changes, you can differentiate them between the radiology point of view. So on the image on A and B, you can see that demyelinating causes such as multiple sclerosis produce a central vein sign, which means that the vein, which is a hypointense part of the lesion, runs parallel to the long axis of the lesion, which we can see in both figures. While causes such as a small vessel ischemic chronic disease produces the vein that runs perpendicular to the long axis of the lesion. Before talking about the evaluation that patients with incidental demyelinating lesions have, I wanted to talk a little bit about multiple sclerosis and when you should suspect it, as it is one of the main differential diagnoses in these patients. So this is a condition that can present with a wide range of symptoms, including visual symptoms such as blurry vision, diplopia, transient, partial, or complete painful vision loss, sensory symptoms such as numbness, tingling, problems with coordination or balance, motor symptoms such as weakness, complete or partial paralysis of an extremity. They can have also bowel or bladder incontinence, and other symptoms such as mood disorders, sexual dysfunction, or difficulty with concentrating or attention. MS is a condition that's mostly associated or presents in people under the age of 50. The symptoms are not transient regarding just minutes, but they rather progress over a period of 24 hours or more, and they persist for days or even weeks, and they cannot happen in the context of fever or infection. To diagnose it, we use the 2017 McDonald criteria, which require the patient to fulfill dissemination in time and dissemination in space criteria. So dissemination in time means that the patient must have simultaneous enhancing and non-enhancing lesions on the MRI, or a new T2 hyperintensity or enhancing lesion on a follow-up MRI. And dissemination in space criteria means that he must have one or more T2 hyperintense lesions in 2 out of 4 areas of the CNS that are associated with MS compromise, which are the cortical or juxtacortical area, periventricular area, infratentorial, which means the cerebellum or the brainstem, and the spinal cord. Because of the time we have, I'm not going to go over the specific different scenarios that we can have to make the diagnosis of MS, but I wanted to highlight that on these criteria, they added the presence of oligoclonal bands on the CSF as an alternative criteria to fulfill the dissemination in time criteria. So if the patient fulfills the criteria for dissemination in space, but only has compromise of one area of the CNS, whether infratentorial, spinal cord, juxtacortical, cortical, or periventricular, but he also has oligoclonal bands on the CSF, then a diagnosis of MS can be made. Moving on to the evaluation of patients with incidental demyelinating lesions. The first step is to do a very complete history and physical examination. This in order to rule out that the patient has had any type of clinical attack that suggests demyelination. So we must go over all the symptoms I previously mentioned that MS usually presents with. The second step is to do different tests and laboratories to rule out secondary causes of the white matter changes. So we have the MRI of the spine. This is very important because let's say that you have a patient with migraine that had a brain MRI done and he's found to have T2 white matter changes. You must do the spinal cord MRI because if he also has white matter changes on the spine, then that means that the white matter changes are not secondary to the migraine, as migraine is not related to spinal cord compromise. So he must have all the other tests done as well. The serology is important to rule out autoimmune and inflammatory conditions, as well as infectious causes. So you must do the serology for syphilis, the Lyme serology, antibodies against aquaporin 4, which are associated with neuromyelitis optica, and some other antibodies such as ANA and ANCAs. The inflammatory markers ESR and CRP, which are associated with inflammatory conditions. The thyroid function, because both hypothyroidism and hyperthyroidism are associated with neurological compromise. Vitamin D, as it is a risk factor when it is deficient, it is associated with MS. B12, because of what I mentioned previously, that the subacute combined degeneration syndrome is associated with T2 white matter changes, and the lumbar puncture to rule out inflammation on the CSF. So we can test for oligoclonal bands, the myelin basic protein, an elevated IgG index, the presence of elevated proteins, and pleocytosis are all associated with inflammatory conditions. After doing all these tests, then you can stratify the risk of your patient as low or high risk of progressing into a definite multiple sclerosis. So over the years, the different studies have shown that these are the most important red flags: being a male patient, being less than 37 years old, the presence of infratentorial, which remember are lesions on the cerebellum or the brainstem with a hazard ratio of 3.7, or spinal cord lesions, specifically on the cervical and thoracic cord with a hazard ratio of 5.11. The presence of enhancing lesions, and the most important risk factor is the presence of oligoclonal bands on the CSF with a hazard ratio of 5.9. So if our patient meets any of these criteria, then it means that he has a higher risk of progressing into clinical definite multiple sclerosis. If after doing all this workup, everything is normal, the patient doesn't have any signs or symptoms of having in his lifetime any clinical attack of demyelination, but he meets the other criteria of having the T2 white matter changes in two or more locations on the CNS, then he can be diagnosed with RIS or radiologically isolated syndrome, which has been described as a group of patients on the preclinical multiple sclerosis group. Some of them are going to stay there forever and are not going to progress into a clinical MS, or they can progress radiologically but not clinically. Specifically, it has been shown that over a follow-up of 10 years, around 51% of patients with RIS progress into a clinically isolated syndrome, which is a first clinical attack of demyelination, or they fulfill the criteria for definite multiple sclerosis. So it's around the half of patients are going to progress. The monitoring of these patients must be done with clinical and radiological things. So the clinical follow-up is the same as the evaluation. You must evaluate the patient for signs or symptoms suggestive of a clinical demyelinating attack, and the radiological monitoring is a brain and spinal cord MRI that has to be repeated every 6 to 12 months. But if he is stable or doesn't have new lesions, then they can be done every year. There is debate whether or not to do it with contrast because, as we saw before, one of the criteria for demyelination in time is having both contrast enhancing and non-contrast enhancing lesions on the MRI, or having a new enhancing lesion on the MRI. And it's a red flag to have a contrast enhancing lesion on the MRI. But others say that it's not worth it to put the patient with contrast because of the risks associated with it. So it's still a controversial topic. The treatment of patients with radiologically isolated syndrome has a pillar of non-pharmacological treatment, which is mostly all the things that you can do to maintain brain health. So the physical activity, having a healthy diet, mostly the Mediterranean diet, smoking cessation and moderate alcohol consumption, and the psychosocial support, which means having an active social lifestyle and a good mental health overall. And the pharmacological treatment, this is like a whole another topic, so I'm just going to mention that the ARISE trial showed, it was the first trial actually that showed that the use of disease modifying therapies of MS, such as dimethyl fumarate or teriflunomide, are associated with a delay in the onset of clinical multiple sclerosis. So the ARISE trial specifically evaluated dimethyl fumarate in patients with RIS and they compared with placebo over a period of 96 weeks. and it was shown that it actually delayed the onset of clinical MS with a hazard ratio of 0.18. However, these treatments are associated with a lot of adverse effects. For example, the teriflunomide has a black box for hepatotoxicity and acute liver failure, and the methylfumarate is associated with opportunistic infections and gastrointestinal upset. So you must balance out if your patient is considered high risk of progressing into a clinical definite MS. So to determine if it is worth it to give this type of medications. And to end, I wanted to give these conclusions. T2 white matter hyperintensities are very common in all age groups. All patients must be evaluated for secondary causes using the history, the physical exam, and the laboratories. They must be stratified into low or high risk of progression to a clinical isolated syndrome or multiple sclerosis, and you must determine the benefits and risks of giving your patient with risk disease-modifying therapy. Thank you so much for your attention. If you have any questions, I'm available for them.